Hello everyone, this is Dr. Humanist again. Let us discuss the main channelopathies in the nephrology, that is Bartter syndrome, Gitelman syndrome and Liddle syndrome. Okay, so we'll see the key differences in three syndromes. Okay, Bartter syndrome and Gitelman syndrome are basically sodium losing nephropathies or channelopathies. Liddle syndrome is opposite, it will cause sodium retention. Okay, and the presentation is also different in different diseases. Okay, Bartter syndrome is, as we know, it is autosomal recessive. Gitelman is also autosomal recessive. Only Liddle syndrome is autosomal dominant inheritance. Okay, other than that, what channels are affected, that you have to remember. Bartter syndrome is basically where the loop diuretics are acting. Okay, that is sodium potassium chloride channels, that is NKCC2. Also the potassium channels in loop loop of Henle itself, that is ROMK, and one more is CIC-KV. So Gitelman syndrome, the channels affected are thiazide sensitive sodium chloride transporter, okay, co-transporter, that is SLC12A3 gene is affected here. Liddle syndrome, ENaC channels are affected. ENaC channels are the channels where the aldosterone will act. Okay, now location, as you know, the thick ascending loop of Henle, that is where the sodium potassium chloride two channels are present. In Gitelman syndrome, the thiazide sensitive NSL channels are in DCT. In ENaC channels are present in collecting duct. So that's how you can remember it. Okay. Next is electrolyte imbalance. All three will have hypokalemia. Okay, all three will have hypokalemia and metabolic alkalosis. What are the differentiating features? The Gitelman syndrome will have hypomagnesemia. So during the treatment of Gitelman syndrome, you have to consider putting magnesium supplements also. Okay. Other than that, calcium. What happens in Bartter syndrome is there is hypercalciuria. Even the calcium is been lost by the nephrons. Gitelman syndrome is not. Like thiazides, you know, one of the side effects of thiazide is hypercalcemia. That's why there is hypocalciuria in the Gitelman syndrome. Okay, but calcium, you know. Gitelman syndrome, there is not much effect on the calcium levels. Okay, renin, angiotensin, aldosterone levels, guys. You have to remember that because, you know, aldosterone channels are been activated more and more. That is a gain of function mutation. That's why now there will be negative feedback going on. That's why low renin and low aldosterone we are seeing in this. Other cases, it's not like that. We are losing the electrolytes, we are losing the water. That's why there will be high renin and high aldosterone in both Bartter syndrome as well as Gitelman syndrome. Okay, high renin and high aldosterone levels. Blood pressure also is like aldosterone, if it works more, as you know, it causes sodium and water retention, right? So it will cause elevated blood pressure. That's why we see elevated blood pressure in Liddle syndrome. In others, normal. Liddle syndrome, Bartter and Gitelman syndrome, the blood pressure will be normal or little low. Okay. Calcium excretion, as I discussed, hypocalciuria in Gitelman syndrome, and Bartter syndrome, calcium will be lost. Magnesium levels, as I said, hypomagnesemia in Gitelman syndrome. Okay, and sodium handling. Okay, so sodium wasting is present in both, guys, Bartter syndrome and Gitelman syndrome. Only Liddle syndrome, there will be sodium retention. Okay, as aldosterone channels are working more, sodium will be more. Retention will happen. How the clinical presentation, guys? Bartter syndrome, you know, it will present in early childhood or during infancy. Patient with Bartter syndrome, no, they'll have even the hearing loss. Right, they'll have symptoms like failure to thrive, dehydration, because a lot of fluid has been lost through the kidneys, polyuria, polydipsia. You know, Gitelman syndrome will present little late, and even the Liddle syndrome will present in adults. Okay, Gitelman syndrome will present with symptoms of hypokalemia, like muscle cramps will be there, fatigue, tetany, chondrocalcinosis because of hypercalcemia. Liddleman syndrome will present with hypertension or symptoms of hypokalemia, just like Gitelman syndrome. Often asymptomatic, as I said, in the childhood, they will present in adolescents or adult patient. Now treatment, what? Because we have to treat the hypokalemia, guys. Okay, so that's why we use potassium sparing diuretics in all three. Okay, to increase the potassium. Other than that, specific treatments, as I said, in Gitelman syndrome, there is a hypomagnesemia. You have to consider putting the magnesium sulfates supplements also. Liddle syndrome, as I said, there's an ENaC channel gain of mutation. You have to block the ENaC channels. Who does that? They are blocked by amiloride, triamterene, and potassium sparing diuretics like spironolactone, which itself blocks the ENaC channels. In Bartter syndrome, you can use NSAIDs, which reduces the prostaglandin and thus preventing the extra channel action. Potassium supplements also, as I said, there is a hypokalemia, so we are using potassium supplements.